Our today's topic is primary open-angle glaucoma Part 4. Vision loss from POG is irreversible. Management is, therefore, aimed at slowing the progression of the disease, thereby maintaining optimum visual function. General treatment. The only proven treatment for POG is lowering IOP. There is now substantial evidence from randomized trials that lowering IOP reduces the risk of progression of POG, Advanced Glaucoma Intervention Study, AGIS, Early Manifest Glaucoma Trial, EMGT, and reduces the risk of conversion from OHT to POG, OHTS, EGPS. However, to date, there is no controlled trials for POG, with randomization to treatment or observation. A multi-center clinical trial based in the UK is underway which will hopefully address this. The study is comparing the rate of progression in early POG between patients receiving latanoprost or placebo. IOP may be lowered by medical therapy, topical and systemic, laser therapy and surgical procedures. There is no strong evidence supporting which of medical, laser or surgical therapy should be given initially. For example, the CIGTS Collaborative Initial Glaucoma Treatment Study showed no significant difference in outcome between patients randomized to either medical therapy or trabeculectomy. Commonly, patients are started on medical therapy with possible adjunctive laser therapy, and only if these measures fail is surgery considered. Unfortunately, some POG patients continue to progress despite lowering of IOP. This provides some evidence that there are IOP-independent mechanisms at play. Therefore, searching for other reversible risk factors for POG is essential. For example, this may come from epidemiological study of POG and identifying lifestyle or nutritional risk factors associated with POG. Medical therapy may be topical or systemic. However, it is important to appreciate that topical medication may cause significant systemic side effects, especially beta blockers. Topical therapy. Alpha agonists, aproclonidine, brimonidine. Beta blockers, timolol, betoxolol, cartaolol, levobunolol, etc. Carbonic anhydrase inhibitors, brinzolamide, dorzolamide. Miotics, pilocarpine, etc. Prostaglandins, latanoprost, bimatoprost, travoprost, etc. The most efficacious class of drops is the prostaglandin analogues. They are also the most convenient drops with once-nightly dosage. Side effects are mainly local and include hyperemia, lengthening of lashes, darkening of iris color and periocular skin pigmentation. These are reversible on stopping the medication. The second most efficacious class of drops is the beta blockers. Topical alpha agonists, carbonic anhydrase inhibitors and miotics are much less efficacious, rarely achieving a drop in IOP of greater than 3 mm of mercury. The best locally tolerated drops are the beta blockers, with very few patients experiencing ocular discomfort or redness. However, beta blockers also cause the most systemic side effects. There is a significant amount of systemic absorption following passage through the nasolacrimal duct. Side effects include breathlessness, reduced exercise tolerance and falls. This is especially true for elderly patients, which is a significant proportion of the POG population. Therefore, non-selective beta blockers are contraindicated in patients with respiratory diseases and some cardiac conditions. Typical first-line therapies are prostaglandin analogues and beta blockers. Prostaglandin analogues are more efficacious and have less systemic side effects. Beta blockers may be preferred in younger patients due to less local side effects, or in unilateral glaucoma to avoid cosmetically undesirable asymmetrical side effects such as lash growth. Systemic therapy includes acetazolamide, carbonic anhydrase inhibitor given orally or intravenously, and the hyperosmotic agents, glycerin, mannitol. Oral beta blockers lower IOP, though are not used for this indication. However, it is important to appreciate that a patient taking an oral beta blocker, for hypertension for example, may have masked ocular hypertension. Furthermore, there may be little additional benefit in prescribing a topical beta blocker for someone already taking an oral beta blocker, though this may cause significantly worse side effects. Please see section Medical Management for primary open-angle glaucoma for more detailed information. Medical follow-up. Once the diagnosis of POG has been established, it is important to carefully counsel the patient. They need to be informed of the natural history of the condition, initial asymptomatic presentation of the disease with irreversible visual loss in cases which are not treated or undertreated. When starting a topical medication, the patient needs to understand the probability of lifelong therapy, potential side effects, the need to use the drops every day, and the fact that they will not notice any benefit. The treatment is preventative. It is important to teach patients how to administer drops effectively. It is popular practice to define a target IOP for IOP lowering. This would be based on current evidence, the stage of the patient's POG and other risk factors for progression. A reasonable initial target is for at least 20% to 30% reduction in IOP. A larger reduction may well be needed for patients presenting with advanced disease. AGIS showed reduced risk of progression for patients whose IOPs were consistently below 18 or largely below 15. First review after commencing a new therapy should occur within 6 to 8 weeks, though the patient should understand to present sooner if they develop any side effects. Thereafter, 3 to 4 monthly review is sufficient if the patient remains stable. At each review, the patient needs the following assessed. Any subjective change in vision or any side effects IOP, is it within target? Signs of progression, standard automated perimetry, optic disc assessment, clinical plus or minus HRT, October. If the patient has no side effects, the IOP is within target level and there are no signs of progression, then a routine 3 to 4 month review can be arranged. If the initial therapy was not at all effective, it should be swapped for an alternative class of drop. If the initial therapy significantly reduced IOP, but not to target level, then an additional drop should be prescribed, or a combination drop used. If there are signs of progression despite target IOP, the target should be lowered further, and the patient more closely followed. If target IOP is not reached despite fully tolerated topical medications, laser or surgical therapy should be considered. Surgery. Non-medical interventions for POG include laser trabeculoplasty, see laser trabeculoplasty, ALT versus SLT. Trabeculectomy plus or minus augmentation, see trabeculectomy. Non-penetrating drainage surgery. Shunt procedures, see section glaucoma drainage implant surgery. Cyclodestructive procedures, cyclodiode, cyclocryotherapy. All these therapies aim to lower IOP. Laser trabeculoplasty is a reasonable initial therapy, especially for patients in whom compliance may be an issue. It is particularly effective in patients with pigmented drainage angles, though its long-term success rate is limited. With the advent of anti-scarring agents, 5-fluorouracil, mitomycin C, for augmentation, trabeculectomy remains a successful surgical treatment for POG. Some studies comparing trabeculectomy to drainage device implantation suggest improved outcomes for drainage devices, though the evidence is still somewhat equivocal and shunt surgery is generally reserved for patients with high risk of failure from trabeculectomy, e.g. previous trabeculectomy, uveitis, aphakia. Non-penetrating drainage surgery is thought to be safer than standard trabeculectomy, but less efficacious in IOP lowering. Cyclodestructive procedures are generally reserved for eyes in which all other measures have failed, or in eyes with poor visual potential. This is due to the risk of long-term hypothony. Surgical follow-up. Early surgical follow-up is discussed in the individual sections on the surgical procedures. Longer-term surgical follow-up is similar to the assessment described above under medical follow-up. Essentially, 3 to 4 month review is sufficient for patients with target IOP and no signs of progression. If target IOP is not reached, or there are signs of progression, further therapy is required. Prognosis. Untreated POG can lead to irreversible blindness. There is not much data on the natural history of POG, as it is considered unethical to not treat patients with advanced disease. One study in St. Lucia found that 35% of untreated eyes progressed to end-stage disease over 10 years. There is strong evidence that lowering IOP can reduce the rate of progression significantly. During 6 years of the EMGT, 53% progressed, though treatment reduced the rate of progression by half, and for each mmHg of IOP lowering achieved, the rate was reduced by 10%. Progression is noted to be worse in patients with more advanced disease at baseline. This may be because an already damaged disc is more susceptible to further damage, or simply that as there are fewer ganglion cell axons, each further one lost has a greater impact on function. The rate of progression and risk of blindness may be hard to predict in individual patients. Some patients progress despite strict target IOPs, whereas others may remain static despite higher IOP. Observing a patient's rate of progression and tailoring therapy according to this is a pragmatic approach to POG. Risk factors for progression include higher degree of optic nerve damage, higher IOP, positive family history of visual loss from POG, presence of a recognized gene for POG, poor compliance and access to good health care, longer life expectancy, presence of systemic cardiovascular disease.